Sorry, it's because it's Chicago time. Hello.
Hi, Abby.
Hi, Catherine. How are you doing?
I'm doing well. How are y'all today?
Good. You might have noticed we have 2 visitors now. This is my lovely friend Nadda Diasti.
Yes.
Last name. She is my dear friend from grad school. She's a speech pathologist, IBCLC as well, and sleep consultant. So we're so excited to have her here. Yeah.
Awesome. Thanks, Netta, so much for being here. It's awesome to have you. Well,
Yeah.
I'm excited to pick both of your brains today, not just one. Remy. And yours too, Remy. Don't worry.
Yeah. So excited to pick your brain.
And what I really wanted to dive into and hear what you'll have to say about, we've kind of touched on it in previous episodes, but this topic of yes, ma'am, and how it really affects a child's development. And I want to kind of take on the perspective of, okay, hey, I'm a new mom and I know very little about tongue ties, but I know that they are a thing. And I'm having a child that is having some trouble breastfeeding, let's say. You say to me first off the bat, can you just tell me I'm feeling confused and lost?
Yeah, I'd say it's very natural and normal to feel very confused because there's a lot of information out there on ties and it's hard to know, like, what am I supposed to take and understand and trust. But what I would say is if you have concerns about ties, like I would first run through like what are the challenges you're experiencing. But ultimately, if you have concerns about ties, I always start with recommending a feeding evaluation, whether it's with a speech language pathologist, a occupational therapist, or a lactation consultant. The key is that they have specialized like niche training in ties because not every provider is trained the same way or has the same level of expertise. And so we really want to make sure that we have someone who we can know and trust that they'll be able to assess and support you through that tongue tie process if need be.
Yes, I agree. I feel like the thing that's really difficult is because we a lot of times meet parents who have gotten already so many conflicting inputs, like either from the lactation consultant at the hospital being like, "Ooh, it looks like there might be a tongue tie," and then they get home and they already go to the pediatrician and they say, "Oh no, they can stick their tongue out, so it's not a tongue tie," and then they're coming to us being like, "I'm already so confused because I just don't even know who to believe at this point."
Yeah. So
that's with trusting your provider, like you said, and finding someone who has trained in this.
And I would also add is a lot of times when families are coming to us, or at least in my experience when they're coming to me, they've already seen multiple people who told them it's just a slight tie, or they're gaining weight and it's fine. And so it leaves parents more confused, but also even more dismissed because they are actually going through challenges. And so in a feeding evaluation, what we would do is be looking at like a thorough case history to really understand like baby's history, mom's history, making sure we're addressing, are there any underlying things that could be impacting like supply if mom's concerned about supply, or is there allergy with baby to consider if that's something that's playing a role as well, in addition to like motor skills and tongue tie. And so we'd start with case history, and then we'd go into a feeding observation. So we may look at feeding at the breast and or the bottle if they're having a hard time with both or would like support with both. And then we'd do like a whole body assessment along with like an oral motor assessment to really look at like baby's function and their sucking skills and like, is there any tension or any asymmetries going on that we need to support? And then from there, we create like a care plan and schedule follow-up visits. I would say at the end of a first visit, I'm never immediately recommending anyone go see a release provider. I always want to start to work on supporting skills. We reassess in our follow-up visits, see how they're improving. Do we need to add someone to the team, whether that's to work on like body tension or and then we determine like, okay, if we are going to pursue the release route, then we would talk about it. We would then prep them and then I'm sending them for release. But I always like to make sure like we're doing least amount of intervention to most amount of intervention to make sure we've like laid a foundation if the release is warranted, but also to make sure that we're supporting mom and baby the best that we can and really supporting they're ready for it, but also building up like strength, endurance, coordination with their feeding skill and like supporting the dyad together.
Yeah, well, I love that, supporting the dyad. And what you the discrepancies you might hear from different providers adds to the confusion of the parent when they make a decision for the child. I found it really interesting that you don't first recommend like a release, you know, in the first evaluation. That's interesting. Why is that?
I think, well, just because, I mean, both of us could probably say this, but like we've seen that and how that goes. And first of all, if it's done like on day 1 or 2, right out of the gate when the baby's just born at the hospital, like the parents have no idea what's going on. They don't have a foundation of even trying to work through the early days of breastfeeding. And so even if the baby isn't latching right away and you have, and which we've talked about in previous episodes, like, and you do need to pump to get your supply in and things like that, like it still wouldn't be my preference to go right away because like Nadda said, like the baby's tongue hasn't even practiced anything yet. Like they've just been in utero sucking amniotic fluid, but they haven't tried with like any type of nipple. So we would rather first try to work on their function and get it as best as we can before doing a release. And also working on their whole body tension, like feeding is a whole body experience. And just also just like helping the mom and dad, like the family, be ready to do something.
I mean, I would say from like a technical standpoint, you never want to just like go and get a release because the release is only one piece of the puzzle. So a release, full range of motion. So the ability to go stick their tongue in and out, side to side, up and down, but it doesn't actually teach them what they're supposed to be doing with their tongue and understanding like all the muscles involved. Like, yes, like the tongue is a component, or if there's the lip or their cheeks, like there are lots of different components that we really want to address before saying like a release is needed. I also would say like Abby said, feeding is a whole body experience. And when there is a tie present, that band of tissue doesn't just stop at the floor of the mouth. It goes all the way down to our toes. So often there are other parts of our body that are impacted. We really need to work on supporting the body, releasing that tension, especially if there's tension like in the neck, because if you imagine like feeding like this and you're scrunched up, that's a very uncomfortable position and just not as fluid as if you were in extension. And so, you know, like a not so mobile neck means you're not going to have a very mobile tongue. And if there's any asymmetry or more tightness on one side versus the other, then that range is already going to limit you and you will have asymmetry in the mouth. So oftentimes like we can see before we get into the mouth, like what's happening on the outside and knowing like, all right, I think this side's going to be stronger or this side's going to be stronger, or they're going to have a hard time doing X, Y, or Z because of what we're already seeing that's happening in the body. And we always have to work like outside in before we like just jump into like the end result is really good sucking skills. But if the sucking isn't there, we can't just go in and be like, here, have a better suck. Like you have to work on maybe jaw strengthening and endurance, or work on addressing the cheek tension or tension on the floor of the mouth, working on releasing and extension in the neck. Or if we do have other like asymmetries, we're working on that too. So it really is a disservice to the family and to the baby to say like, let's just go get a release, especially in cases I've had where like the baby is actually, that band of tissue is like giving them the stability that they need. And once you release that, they're just all over the place. Like, and it can cause way more instability. So I've seen like the impact of like that was actually helping them in that moment because they were compensating. They were just having such a hard time. So we always want to do motor feeding, least amount. And then as we're reevaluating, we're seeing like, okay, are we making improvement and things are going well? Okay, it was more probably tension, dysfunction versus tie, or are we kind of like plateauing, or isn't that much change? And that's when we're reevaluating the need for release.
Interesting. Yeah, I find that all very interesting, the distinction between tension and dysfunction and an actual tie. And that you kind of have to wait.
Yeah, you do have to wait. And it's not just wait and see, like we're not gonna do anything. You're intervening, like you said.
And seeing.
We're supporting and seeing. Like we're doing the feeding therapy. Like, I mean, I had a patient just recently where I thought in the back of my head, oh, maybe it's gonna be a tie, but I didn't say anything yet because I was like, I'm not gonna freak out the parents on day one about this. And sometimes I do. Sometimes I say, and I did say to them, like, okay, I'm gonna keep assessing their oral function. But I didn't even get into the full tie conversation yet because I was like, let me give them some time. I gave them the exercises. And then the next session, the baby was doing better and more efficient at the breast. And I was like, you know what? I don't think it's a actual structural problem. I think she just needed to work on her function. And
I would say too, a lot of the times we're hearing like the mild or severe tie. And that is when we think about like, there are different classification systems to identify the point of insertion of the tie. So is it at the front of the mouth or the back of the mouth? Or how closely does it attach to the gum line? And so that is like what the marker of severity is. It's not like you have a mild tie or a slight tie, because if function is being impacted, then you have a tie. It's not like a range of severity of the tie, because if someone is having challenges, there's a tie present. But, and I think that is also often misunderstood as well.
Okay.
Yeah.
Okay.
I think what were you gonna say?
Well, I was just gonna ask, I guess, further so when you talk about like mild tension, that's still considered a tie. It just perhaps the baby can adapt in terms of feeding.
I think I'm going to clarify more. So what I'm saying is when there's a tie, it's not that it's like mild or not mild or severe. It is that like there is a tie present and it's causing functional challenges. As an infant, I'm thinking functional challenges are related to feeding, sleep, or airway. And the severity is the point of insertion. So thinking like an anterior tie, that tie that's like at the tip of the tongue, versus a posterior tie that's like further back in the mouth.
But both could be impacting function the same way.
Yeah. And technically we have 7 bands of tissue. So you could have 7 ties, but more often it is like lip and tongues that are impacting function. And then sometimes the cheek is, but we are never quick to be like, let's do all of them at once. Does that answer your question?
Yeah, it does. Thank you. And Abby, what were you going to say?
I was just going to say that I'm forgetting.
Well,
okay.
What I was going to say is, so you were saying like, oh, I wasn't sure about this baby. So I've had a case where like a baby had a super anterior tie. So like as soon as they open the mouth, you can see that band of tissue. But this baby, when we did body work with a physical therapist, oral motor work, feeding support, supporting mom supply, like they were triple feeding at the start when they met me at 6 weeks. But I think, 4 or 5 sessions later, this baby was a night and day difference in like, they were able to take a pacifier. They had full extension. Mom had a full supply. They were feeding beautifully. And although that tie looks severe in its appearance, they're actually doing so well. And so we chose not to pursue release, and we're going to reevaluate her skills when we start solids.
Okay.
That was along the same lines of what I was going to say, actually. It was about Remy. Like I was fully, like after going through it with my son, I was like, oh, there is a genetic component. Like maybe my second kid is going to have a tie too. And I was so surprised that in the beginning, like I did notice that she had tissue you could see on her lip, but like because I was able to address the function and like help her flange her lip, like it's so flexible that I don't even think like it didn't impact our feeding journey. And like I just thought that was so interesting, because if you look at her tongue right now, people would probably say like, or at her lip, I mean, people would be like, oh, that's a lip tie. But it's like you can't just assess it based on the way it looks. You need to see like the whole picture of how the family is doing and how the baby's doing.
And I would also say it is a red flag to me if someone says, oh, it's just a lip tie, because in my experience, I've never seen
just
a baby who has a lip tie without a tongue tie. Like maybe there's tongue without the lip, but
they usually go together.
99% of time, like it goes together.
Yes.
And that tongue tie is usually a posterior tie.
Interesting. So say that I'm a mom and I want to just see what happens. What happens like just looking longitudinally, if I don't get a tongue tie release, and it actually did impact my child.
I would say like there's so many different versions, but if we just talk about some of the ways it could go, and you might not have every single symptom that we're going to lay out, but like this is the way it often goes. And I work with adults with tongue ties too, so I also like hear the whole life story, and I'll hear the whole thing, and they'll say, and this is like an adult I'm talking to, right? They'll be like, oh yeah, like when I was a kid, I was in speech therapy for my S's and my R's. And like, oh yeah, my parents also said that I had, like, I was really colicky as a baby. And I also had like reflux, and like, I was definitely a picky eater. Like I never liked different textures. And I also had, you know, like now I have TMJ because, and I have headaches, and I also have sleep apnea. Like there's so many different things that it can relate to. And we can kind of go more step by step, like the other way, like from babyhood, what you would see. But like that's when I'm talking to an adult, like what they reflect on. And as I explain how the tongue like shapes your palate and shapes your airway development and everything, they kind of piece all these things together and are like, wow, like if only someone had met me as a baby and recommended a tongue tie release, and like that could have changed everything.
And I think like to the parents who not wanting to pursue release, it's not the end of the world, but what's important to understand is that we don't ever grow out of these things. We grow into more compensation. So babies, we're all smart, right? Our bodies will adapt to things that we may not be able to do well, and then we start compensating. So it's going to just continue, and that we have to be aware of that. So it's not like that they're fine or they just grew out of it, but more so like they're finding a way to compensate so they can feel better and do better. But it doesn't mean that it's not impacting them. But what I always share with my families is like, if you are not interested in pursuing release, like that's fair. Yeah. We don't have to, but we're going to do everything that we can to that's within our control to support the baby. So that means like we're doing our homework, we're doing the tummy time practice, we're working on the body, we're doing oral motor work, and like we're making sure we're protecting supply. And then like when we start solids, right, we're looking at those skills, seeing what we can do, and we can reevaluate and see like, okay, is this something that needs to happen? Or even as babies get older, if we're seeing more sleep challenges, like really always want to address root cause, right? Things are not going to change or get better if we just have like, if we're just putting Band-Aids on these symptoms. I think that's just definitely something to consider. We've definitely become a culture of like, we turned out fine, we're okay, this is normal.
Rub some dirt in it.
Of like what is normal actually is just very common, but it's not normal. And I think like we would all want what's best for like our babies, and that
now we know better, so why don't we do better? On that point, like just to give more context from like starting in utero even, we were talking before, we're not sure, it's somewhere around 6 to 12 weeks that you start developing like these tissues in your mouth, and everyone has those 7 tissues for stability. But when we look at like cavemen, we used to have wide jaws and wider faces where you could fit all of your teeth, and we didn't have to get our wisdom teeth pulled. So like even orthodontia is starting to, and dentistry is starting to come around now to, instead of pulling teeth, like doing myofunctional therapy, we call it, to think about where the tongue is in the mouth, and do palate expansion and try to help babies and kids develop their palates so that they can have better breathing and better just overall health. And so I feel like that's where the lactation consultants come in, and this early identification of like, okay, if we can just release tongues, or at least get better tongue function at an earlier age. So like even just simply like pushing up on the bottom of your chin to babies and getting their tongue to the roof of their mouth, getting their lips closed and letting them breathe through their nose. Like every baby should be doing that, even if they're not going to get a tongue tie release.
And sometimes
they can't.
They can't, right? Like we'll start doing these exercises and we'll realize like okay, we can make contact, but we really can't maintain that elevation. And that's really due to something underlying. But that, to your question about like the long-term implication and like starting in infancy, is like the longer we wait, the more interventions that's going to be needed. So it's like if we have a 2-year-old, we can't just go and do a release. Like we have to first build trust, work on function, like start bringing awareness. And then we have to consider like, what is their palate shape now? Like, is it very high?
Narrow.
Is it narrow? If we do a release, we're just going to risk relapsing. We have to actually add in another intervention like palatal expansion to make sure that the palate is wide enough for the tongue to even fit. Because if you just do the release and the tongue doesn't have enough space, then you're not going to be able to have optimal function. So there are just like way more layers that can come in, more time, and like palatal expansion isn't cheap. And so that's also something like
it's not that we have to for like a 12-year-old. So that's why we're just like such big proponents of like early intervention when it is really necessary, because we've just seen how it can affect throughout the lifespan.
And we're only recommending releases if we truly believe that they're warranted. Or at least in the approach that like we're taking in practice of like, I'm only sending a family if I really feel that they would benefit. And we've done everything we could so far to support them. And now like things are showing us like, okay, this is really the tie that's impacting, and it would be supportive for them to get a release.
Yeah, really interesting. All such good stuff. I want to, well, first, Nadda, I know that you talked about this, Abby, with seeing adult clients with tongue ties, but tongue tie and sleep. And what is, Nadda, can you speak a little bit more to how it affects sleep? And then I'd love to hear from you too, Abby, from the both adult and infant perspective.
Yeah. So when we're thinking about sleep, I think in general, what we should start to think about is just our rest posture. So that rest when we're awake, if we're not talking or eating, and when we're asleep, our tongue should be suctioned up to the roof of our mouth, right behind our fronted teeth, lips are sealed, teeth slightly apart or not touching, and breathing through our nose. So you might be noticing this about yourself right now. And this is so important for sleep because first is that like nasal breathing is what allows us to breathe in filtered air. And if our mouth is open and our tongue is down, then we're breathing in unfiltered air that with over time can increase inflammation and then contribute to enlarged adenoids, tonsils, nasal turbinates, which then can impact our sleep and our airway. And then when we're thinking about just like sleep too, is that a tongue, when it's suctioned to the roof of the mouth, is what allows our body to go into like deep REM restorative sleep. If our body is not able to maintain that elevation, then we're kind of basically in the state of just like active fight or flight, because you can never go into true deep sleep. And even if we have a kid who's like sleeping like a log, it's the quality of the sleep is being impacted. And as we get older, we see that play out within like impulsivity or ADHD like symptoms. These are like a lot of behavior kids. It can contribute to like learning challenges because we're not getting good quality sleep. And in a younger child too, thinking of like our tongue up to our palate is what like calms and regulates our nervous system.
And activates your vagus nerve, which like gets you into the rest and digest and like deeper REM sleep, like you're saying.
And so for many of our kids too, a lot of the things that happen, or what I see, are these babies who are like, I need to be latched on all night long. And it really is like, I'm just trying to help myself breathe better and soothe. Yeah, because your tongue is able to do the job, so we're seeking it out in other ways. So having that breast or the nipple gives them that input, or finding finger or the pacifier. And so a lot of times when I'm working with families, we always need to look at the root cause, whether it was tie related or something else, because if we don't address those things, then we can't expect to reach our goal if there's something underlying that's perpetuating that frequent waking. So with ties, the most common things that I'm seeing are frequent waking, super restless sleep, hourly wakes, and they're all very connected. And oftentimes, right, the first sign that we're seeing is like mouth breathing or low tongue posture. And mouth breathing is one of the first signs that we're seeing that is a sign of sleep disordered breathing. And as we perpetuate that mouth breathing, that can just progress into sleep apnea down the
When they're
road.
older.
And then some of the other signs are like snoring or noisy breathing or sleeping in hyperextended positions to help open up our airway.
Always on their stomach.
Yep,
Yeah.
stomach, bum in the air. So there are a lot of different things that we're looking for to see, like, is this impacting my baby's sleep? To help us kind of make sure we're addressing a full picture for the family.
Wow,
So
so
much. I
interesting.
love it.
I know, it's awesome. It's so interesting, especially the part about the tongue on the roof of the mouth, the vagus nerve, REM sleep. Fascinating, because you think you hear of these behavior kids exactly that have a bunch of comorbidities. So it's just interesting to understand, perhaps from a root cause perspective, what it could
Yeah, and I think it's so important because so much of, which is like, could be a whole different topic.
Yeah.
So
Sleep.
much of the sleep world is about like making our babies sleep at a certain time for a certain number of hours in the night. And if we're not doing it, we're like, oh my gosh, something is wrong. And oftentimes, like, there really isn't anything that you're doing wrong. Your baby is just being who they're meant to be and like doing what's biologically normal. But on the other side of things, like, there are, when we really are having a hard time of like, we're waking up hourly, baby is super restless, having a hard time resettling, even like with all the supports, that's telling us like we really want to take a deeper look and figure out like what is going on that's impacting that nighttime or daytime sleep for this child. And like, the time may be a part of it, and then there are other components to consider too, but we always want to rule out those underlying causes so that we can make sure we're addressing the full picture.
Yeah.
Wow. Okay, I'd love to get both y'all's thoughts on, I don't know if you've ever heard of this, but mouth taping for adults.
Oh, okay. Well, I'll take this because it also has to do with the adults and the sleep apnea.
And for the listeners, it's this idea of taping your mouth when you go to sleep, which I'm not gonna lie, I do it every night. So
you already do it? I didn't know that.
I do
Thoughts on this, so I'm
I
curious.
have thoughts.
I
Okay.
actually have never talked about this.
Yeah, we'll have
so
to discuss.
I'm curious.
Okay, so my first, to just explain, let's say, okay, there used to not be as many lactation consultants or emphasis on breastfeeding or whatever, and a lot of our clients end up just going through life, and then they never really think about their oral function or swallowing or any of this or breathing, and then they get to like age 35 and they all of a sudden have sleep apnea, and so then they are referred to us to do to a speech pathologist to work on their swallowing and their or myofunctional therapy and all of this. They are now, like, when I explain all of this to them about putting their tongue on the roof of their mouth or even swallowing properly, they're shocked. That tongue thrust is also involved with this, where their tongue is just, like Nadda said, like developing all these compensations over the years. And yeah, they're eating, talking, and sleeping and breathing, but like not the best way. And like, even with speech, a lot of them tell me like they are teachers or they're businessmen, and they talk all day and they're so tired and fatigued by the way that they're breathing, the way that their mouth is moving, or they feel like it's effortful, or they stumble over their words. Like, there's so many effects. But to focus on sleep, sleep apnea is when your airway is actually obstructed throughout the night, and it can be diagnosed by a sleep study where they really measure your breathing and heart rate and all this stuff. And it, as you can imagine, has terrible long-term effects with like not getting oxygen to your brain throughout the night. So what Nadda was talking about with babies and noisy breathing is usually classified as sleep disordered breathing. It can also be full obstruction and sleep apnea, but it usually, with older people, when that's diagnosed, like, they recommend a CPAP. But again, that's another compensation. So that's like the mask you hear of to put on. Now people are getting more holistic and trying to think about, can we do palate expansion and try to make more room for the tongue and try to do myofunctional therapy to strengthen the throat muscles and the airway and all of this stuff. So we try to do that. One of the things we try to do, and I believe that you definitely need to make sure that the nose, like an ENT, so an ear, nose, and throat doctor, has looked at the airway and the nose first to make sure that your nose and throat are able to breathe in the reclined position, and breathe well, before you can like recommend that you tape your mouth. Some people do just try it on a whim, but and the goal would be, of course, to train your nasal breathing at night. but you need to make sure first that your nose is working and your airways open at night in the back. And the other thing is like there's also a developmental piece to this where like if your tongue wasn't up your whole life, a lot of times you have a more high narrow palate because the tongue wasn't like widening out your palate throughout those years. And then also like your lips can even be like open at rest. Like they have a hard time meeting and closing. So if you just use tape to do it, that can be, it's another Band-Aid, literally, like compensatory strategy. Now, let's say your nasal breathing is great and you do the mouth tape and it helps you get a more full night rest. Some people will tell me that. They'll be like, oh my gosh, I tried it and it's amazing. I like slept so much better and blah, blah, blah. And then if they try it during the day, they also feel like I can breathe through my nose very well. I don't feel panicked. I feel totally normal. And that's the case where I think you could use mouth tape. But I don't think you should just like necessarily try it on a whim if you're having all these other symptoms, because you need to look into all the root causes further. What do you think?
I mean, I agree. And I think that like, you want to make sure that the airway is clear, but you should also, before you even doing nighttime taping, like if you're gonna
try it during the day.
Can you nasal breathe for 3 minutes straight at least with a tape on your lip during the daytime? If you can't, then you really shouldn't be doing it
for
at
12
night
hours a night or 8 hours.
Then that's not safe. But the other thing that I think of too is that like I would never personally, at least right now, would like cover the lips too. So like around the lips we can seal because in case you do need to compensate and you do need to open your mouth at some point, then you have access to that. I use taping, like kinesio taping, as a technique in my therapy sessions with infants and toddlers, where if there is a lot of low tone, like we'll do lip taping, might do cheek taping, even jaw taping to help increase that and decrease some tension. And it's really supportive, but like you really have to make sure that the baby or the client is a good candidate for it before we implement something like that.
That's a good point.
Really interesting to hear y'all. I'm still a believer.
Oh, well, no, I will say, like, no, I am a believer as well, as far as like if it's in, and same thing. I think that's what we're saying about this whole conversation about tongue ties, lip ties, you know, mouth taping, like jaw development, palatal expansion, like all of this is like, these are all the options that we know to combat the issue that like we all aren't like breastfeeding for 5 years and eating resistive food like in the wild. Like, we're all not developing our jaws well. It's so that's why we're like, okay, let's try to use the right bottle nipple and the right pacifier to try to like and minimize pacifier use, like do all these things to try to get the tongue and to function well and the jaw to develop better, so that like people have less issues throughout life, which could even be like sinus issues, or just we need just better breathing in general, and that could probably help all of our health as far as like, you know, leading to, I mean, I don't want to make crazy medical claims, but like I do think that like breathing is like an underlying medical thing that no one's thinking about, or a lot of people aren't thinking about, and then we wonder why we have like these issues later in life with like
what it makes me think of is like in high school we all learned like the mitochondria is like the powerhouse of the cell. Breathing, but like your tongue is basically the powerhouse of your body, and if it's not doing the right thing to support us, then we're going to see impact throughout the lifespan, one way or the other. Could be subtle, but like your tongue really is one of the most important things that
they say is the strongest muscle in the body,
and like it's the most often overlooked part of our body
because it's hidden and
so interesting.
It's an ending,
like so many good things this whole episode. Nadda, I so appreciate you coming on and sharing all your sweet genius with us. And
we love nerding out about this, so we're like, you know, we need to just
it's amazing. I feel like I'm just profiting for free from y'all's wisdom and knowledge.
No, you're awesome too. We love you.
Thank y'all both so much. Nadda, we'd love to have you back on sometime.
I'd love to come back. Let me know when.
Please do. And thanks so much. All right, we'll see you next time.
Thanks, Catherine.
Thank you.